Hi, my name is Norm Sweet. I'm the Director of Behavioral Health for Harbor Health's Community Health Centers. I'm here today to talk about motivational interviewing, particularly the practical applications. We'll be talking about what actually motivational interviewing is, the 6 stages of change, misconceptions of motivation, which is very important to recognize, and one model for brief interventions, we call it frames. The idea behind motivational interviewing is to change or not to change, and that's the heart of the whole model. It's about ambivalence. There are three types of conflicts that I'll discuss. You will see different interviewing traps and then some techniques to address those traps. And yet, sometimes people still resist making any change in their life. And then I'll show some signs of readiness to change. The important part is the negotiated plan, that's the patient's plan. And then we'll conclude. So, what is motivational interviewing? It's an approach that helps people recognize and do something about their present or potential problem. Miller and Rolnick developed the model actually in the late 1980s. It was actually used for substance abuse. So I took the quote here from Motivational Interviewing, preparing people to change addictive behavior. Since then, it has moved into mental health as well as organizational change. What are the 6 stages of change? Prochaska and DiClemente, 6 stages of change, talk about pre-contemplation and then moving into a cycle of contemplating, making a determination, having action, and then leaving that cycle. Using substance abuse as a model, people often, quote unquote, relapse and go back into the cycle. One of the things that we making the mistake on when we're working with somebody who's not ready to make any change or never really thought about making change is that we hope to get them from pre-contemplation to permanent exit, and that's not realistic. Change is hard for all of us, whether it's a small change or a major change. And the idea is to keep trying until you're out permanently. If we recognize this with patients when they're coming in, it'll be less disappointing if they make a mistake or they don't do too well. Now, these next two slides I think are very important. We have misconceptions of what motivation is, and this is about making change, if somebody's motivated to make that change or not. Sometimes we make an error and think somebody's actually motivated to make a change if they just simply agree with us in the exam room, if they accept a diagnosis, or if they express desire or need for help. A lot of times, folks who come in, if they are having difficult times quitting smoking, they might know that the provider thinks that they should quit, so they'll say, yes, I need help, but may be not ready to make any change. They might present as distressed over the condition, and they might follow advice. Remember, even any of these doesn't necessarily mean they're ready to make any change. On the opposite side is when we think somebody is not motivated to make change, when they actually might be very motivated to make some kind of change, even if it's not the change we're looking for. Examples, they might disagree with us. They might refuse the diagnosis. We see that sometimes in mental health where we might say somebody looks like they're depressed and they are upset that we said that they look depressed. That's just one example. Diabetes might be another example. There might be denial. They might express no desire or need for help. They might have family resources. They might have other ideas on what they might want to do. They might not present as concerned. A lot of folks can present as maybe in shock or stoic. And if they don't want to follow that advice, it doesn't mean they're not going to try something else. There are a few different models of looking at motivational interviewing. I chose frames in particular because it's simple, it's straightforward, easy to remember. F is feedback. We want to provide feedback to patients if they have questions or if they express concerns or not really sure what to do, or if they have family resources that might get involved. Responsibility is really the patient's, it's not ours. A lot of times when we're working with patients, we take on this idea that we have to make the change for them or that we're responsible for their change. Patients actually should be responsible for their change. And advice, and it's not moral advice, it's really advice about evidence-based information. Bringing down the A1Cs helps in the long run with their health. If they quit smoking now, so many years down the road, they'll be much healthier versus if they continue smoking. And a menu of options. It's a toolbox. The more patients have in their toolbox for ways to make those changes, the better chance that they will actually make some change somewhere else. Empathy is different from sympathy. Sympathy is more along the lines of feeling bad for somebody. We often hear that when somebody passes away. We feel sorry for somebody, or we'll reach out to them and express our sympathy. Empathy is much different. Empathy is really walking in the shoes of somebody else, not necessarily condoning their behavior, but actually just understanding how they're feeling because of the situation or the circumstances that they're in. If we mix up sympathy with empathy, it'll be very difficult to connect with a patient. And finally, in the model, this is very important, other models do not have, is self-efficacy. A person must believe that he or she is capable of accomplishing tasks. If a person does not feel that they are able to make any of those changes, they're not going to. Ambivalence to change or not to change? That is the question. Working through the ambivalence is working through the heart of the problem. Patients might feel stuck. We need to tip that balance. There are healthy choices and unhealthy choices, and we have to help them see the benefits of the healthier choices and less of the benefits of the negative choices or unhealthy choices. Letting go of attachment to old behaviors is very difficult. We need to see replacements, and that's for all of us. Especially the older that we get and we have these same behaviors over and over again, it's harder to make those changes. Sometimes we don't even recognize that we're holding on to certain behaviors. We have to be careful with assumptions that a person sees the world the same way we do, with their value system, their expectancies in life. Self-esteem, if they don't have a self-esteem, they might not be able to make the change. The social context, and this is very important. It's not just peers, it's family, parents, children, cousins, anyone in the community. It could be church, it could be a community group. That's very important. A lot of times patients' environment will impede any of the possibility of making change. For example, a patient who has diabetes finds out they might be in shock, they might have children, they might have a spouse or a partner, they might have difficulty affording healthy food, and it's much easier to buy cheap food that's not healthy. So it's very difficult sometimes for all of a sudden to make significant change. Then there's something called a paradoxical response. We see this a lot in substance abuse, but it happens in other areas as well. When somebody looks like they're ready to make change, they might even talk about they're going to start that day, the next day, they're going to talk about what the changes are going to be. For example, someone wants to quit smoking. Maybe they're smoking a pack a day, and they said that even cutting back to half a pack tomorrow. They come back in the next week and they're smoking a pack and a half instead of the half pack. That's called a paradoxical response. They went the opposite direction. If we go back up to letting go of old behaviors, when we try to let go of old behaviors and we don't replace them with something else, what happens is a lot of times people get anxious, they might feel guilty, there's a loss, and they overcompensate for what they thought their loss was going to be. So that's really important to remember. I think a lot of times when we see patients and they come back in and they are doing worse, and we think they're doing worse than they were before, or more engaged in unhealthy behaviors than they did before. It's an actual natural response, and it's important to educate patients on that and the peers that you work with. Okay, now we're going to move to three types of conflicts. The first one, approach. You have two positive or relatively healthy choices. We could have two different salads, and we have to choose which salad we want to eat. That's the kind of a conflict that we all want. Either way, you're going to win. The avoidance is kind of the opposite of that. It's the lesser of two evils. We have two unhealthy choices, two things that we really just can't avoid. We have to choose one. It's really the lesser, the one that's going to have less damage. Now, the approach avoidance is what makes the work that we do so difficult. Again, it's like the quitting smoking. A patient might want to approach the smoking cigarettes, or they might want to avoid smoking cigarettes, but they're ambivalent, and the ambivalence is having them go back and forth between the two. So we want to help them avoid the unhealthy and approach the healthy. Interviewing traps. A lot of times when we're in with patients and we're talking with them, we can actually fall into traps and we don't realize we're doing it. A question answer trap. Person does not elaborate or continue discussion. A lot of times that's a yes no, or they shrug, or they don't really respond. We're not really helping them elaborate. Then there's the confrontational denial trap. Person doesn't feel comfortable being honest or is unaware that what is being said is not entirely accurate. And we have to be careful that we don't confront them too harsh, especially if something doesn't seem like it makes a lot of sense. Then there's the expert trap, and we see this a lot in primary care, even behavioral health. Patients come in and they expect us to be the experts. So what we say is the way it should go. And sometimes we actually can fall into that, where we assume that our recommendation, even if it's evidence-based, has to be the way to make the changes. And it's not always true. We have to step back and realize that it's patients' life, and we're lucky to be able to help them on their journey. They're opening that door for us, and we have that moment. It's that window. There's a labeling trap. Person is a diabetic rather than a person who's managing diabetes. that's very important, that it doesn't become their identity, and we don't start looking at them as that's who they are, because then we miss everything else about their lives. In behavioral health, I I work with my staff not to call patients with schizophrenia schizophrenics, or patients who have substance abuse issues addicts. What happens is we do that, then we start to have this image, and it could be a false image of what we think they're doing, what their motivation might be. Then there's a premature focus trap, looking at solutions that aren't realistic, or they're not going to be met as quickly as they seem. That person who might want to quit smoking, assuming that they're going to quit tomorrow, all of a sudden out of the blue, we have to be careful. Is this realistic? Do you have the tools to do this? Somebody who just realized or just found out that they have diabetes and they're going to change their whole diet, they might still be interested in having some fried food or soda or whatnot. So we have to be careful to assume that just tomorrow they're all of a sudden going to make that change and be from pre-contemplation to permanent exit. Then there's a blaming trap where if we confront the patient and they might feel that they're being blamed for their behaviors and they can't make the change, they might get defensive. They might feel guilt. They might feel embarrassed or even shame. They feel it's his or her fault. We have to be careful not to make them feel that way. They might not even come back. So, what can we do? There are interviewing techniques. We ask open-ended questions instead of closed-ended questions. The who, what, where, when, and how. Avoid did you do this? Why didn't you do this? How come? Even the question why. We have to be very careful with that, and a lot of people struggle with it. A lot of times, it's not necessarily the word why in and of itself or the question. It's the tone of voice. It's how we say it. It's like a parent saying to a kid, why didn't you do that? Or why did you do that? Um, it can make us feel defensive. It can make us feel attacked. It can make it feel punitive. So just be careful with the why. Sticking with who, what, where, when, how, or even tell me a little bit more helps them open up. Then there's reflective listening. It sounds like what you're saying is this. You're saying that it helps them hear back what you think they're saying. And if we're wrong, they can correct us. I use it all the time, and it's very helpful because then I feel like I am understanding and on the same page as somebody else. Affirm or validate. It's tough to handle what you have to handle. That happens a lot with somebody who just got a diagnosis with diabetes or is just contemplating quitting smoking. When we affirm or validate somebody's experience, their feelings behind it, it's the empathy again. It's walking in the shoes. Doesn't necessarily mean we condone behaviors. Behaviors need to be separated from who the person really is and how they're feeling. People have automatic thoughts, and those automatic thoughts impact how they feel. Then they have a history of how they react to those feelings, and that's where the behavior comes out. So we help them think about things in a different way, feel a little bit different, and hopefully the behavior starts changing. Another technique you can use is summarize. There are times when we're with patients and they'll talk the whole session, and it's very hard to even ask the questions we need to ask for the medical record. So we can't reflect everything back. So just do a summary, recap it, paraphrase. And the idea behind all of this is you want to elicit self-motivational statements. What do you think you can do? What things are you thinking about doing right now? Even what small change do you think you can make tomorrow? What is it do you think that needs to happen in your life? And yet the person still resists. It's very important to continue using those techniques, elaborate more. If a person appears that they're resisting, we have to step back and think, are they really resisting? And there's some behaviors that we really need to avoid. Arguing. If a patient is arguing with us, we got to make sure that we don't argue back. If it feels challenging, if they're discounting, even hostility. If they're interrupting, talking over you, cutting you off, a lot of times that means they feel like they're not being heard and there are things that they want to share, or they want to avoid the conversation that you're trying to have with the patient. It's a technique that a lot of people use to stay away from uncomfortable discussions. They might deny, blame somebody else. They might disagree, make excuses, claim impunity. This is not my responsibility. It's not my fault. They might minimize it. They might be pessimistic. They might be reluctant. They might just be unwilling to change. Period. They might just ignore us. There are times when we're in with patients and we're sharing evidence-based information or we're talking about diagnosis. Maybe their mind's wandering somewhere else. Maybe they're in shock. Maybe they just don't want to hear what we have to say. Inattention, no answer. They might even start another conversation and sidetrack. Signs of readiness to change. This is very important because this is when you start really seeing the window of opportunity. They have decreased resistance. They stop arguing about the actual, maybe the diagnosis, for example, or the change. They might start talking about something else, like how do I make change? They might decrease questions about the problem in and of itself. They might not be asking as many questions that seem to avoid taking care of her or himself. One of the best signs is resolve. A person makes definitive statements. It's almost like seeing the light bulb go on, and you know that they're going to do it just the way they're presenting themselves. There's this confidence that they're making that change. And they might even start showing it, even if we didn't expect certain behaviors. But it might be a person diagnosed with diabetes all of a sudden starts walking the next time they come in. They never walked before. Making self-motivational statements. They make action-oriented statements. I'm going to do this. I'm going to go for that walk. I'm going to try to have a salad if I have to take the kids to McDonald's versus having that Big Mac. Positive self-talk. They feel better about themselves. We can often see self-esteem increase when they're making the changes. They can also present as a little bit anxious too, even if they have the resolve that they're making the change. That's normal. Change is scary for all of us, especially if we're looking at significant change or if it's going to turn our lives upside down. If somebody's diagnosed with diabetes, that's a lot of changes in somebody's life that they might have to address. Can be quite scary. They might even feel shame or not want to share it with family members. So even if they're making changes, they want to make change, there could be other factors that are influencing them emotionally. They might increase their questions about the change. They might ask more questions about the benefits of being healthy, how to do it, resources. Envisioning is wonderful. A person starts talking about what life could look like. They start envisioning themselves somewhere else, down the road. It could be a month, 6 months, 5 years. When they start talking about differences in what their life can be, it helps them give a direction. One of the things that I love about behavioral health, and primary care does this as well, is that a lot of times we're stuck in the forest and we can't see the trees from the forest. And we're just meandering around circles and circles, or we're kind of repeating ourselves, or the same behaviors, or going around in the same little paths. We don't realize we're doing it, and we're trying to get out of it, and we can't figure out how to get out of the forest. We don't know where the exit is. Once we start having a vision of where we want to go, then we can start moving in that direction instead of just meandering. Experimenting, this is great as well. A person comes back and talks about trying something else instead of doing what they have been. Somebody who might want to start losing weight. I worked with one patient who wanted to lose weight and didn't know what to do, and they came back in the next time and said that they made smoothies for breakfast instead of having a big meal. Um, Changed a little bit of their diet that day. Tried a different exercise program, and they started doing some experimenting. Somebody who wants to quit smoking, they might try something like Nicorette or Chantix or put a patch on. They're just trying to see what they can do, even cutting back. If they're trying not to smoke cigarettes first thing in the morning when they get up. Those are examples of somebody trying to experiment to make change, and that's a really great sign. Possible key questions you can actually ask a patient when they're in the exam room. What do you think you'll do? What options are you thinking about? It must be uncomfortable or difficult for you now with what you're dealing with. What do you think is the next step, even if it's a small change? What do you think has to change? What in your life is important for you to make changes? What do you want to ultimately see happen? What are some things that you can do to start moving in that direction? And negotiate a plan. Again, this is for the patient. They have to be responsible for their treatment plan or their self-management goals. If we have a treatment plan for them, a lot of times people are not going to push forward with it. So we want to set goals, consider change options, and again, it's a menu. Arrive at a plan that works for them. Elicit commitment. What part of the plan are they going to work on now at this point? And I often use the scale from 1 to 10. 1, you're not going to do anything. You're not going to make any change. And 10, you are absolutely committed and you want to make that change. Surprisingly, a lot of people have some insight in this and they know where on that scale they might fall. Some people are absolutely resolved and they're going for that 10. And I've had several patients say, no, 1 or 2, it's really probably not going to happen. So that means we have to renegotiate a plan. Then we want to transition to that action stage when we elicit that self-motivational statement that they're going to make that change for themselves. So motivational interviewing, this is a brief overview of practical implications for the use of motivational interviewing. There are several resources out there to use these skills in depth. More formal trainings, we would actually do role plays where somebody was a patient who had to make a change, or we were hoping they would make a change, a provider and an observer. And the provider would practice the motivational skills, and the observer would help support, and then the patient would be able to give feedback. One of the beautiful things about the role plays is that person who becomes the patient starts to experience what a patient might be experiencing, and we can help have feedback with the provider. So that is it. Feel free to contact me at any time if you want more training or you have any more questions about motivational interviewing. Take care.